Hello and welcome to the Institute of Healthcare Management's latest webinar, where we're thrilled to have as our guest once again Dr. Jonny Pearson-Stuttard, public health doctor and clinical academic at the Imperial College London. Jonny's going to be fascinating us, I'm quite sure, with the second in this series on population health management. There will be some Q&A opportunity at the end. So as we get towards that, do please type in your questions. You'll see the box at the bottom of the screen to enable you to do that. And we'll go from there. So without any further ado, Jonny, over to you. Thank you.
Thanks, John, and thanks everyone for tuning in this evening. So back in November, we gave a sort of broad overview of population health management and what it is, why it matters, and what it means specifically within the NHS. So today we're going to focus a little bit more on one element of that, and specifically around data, and talking you through various different aspects. So the three different areas that we'll cover specifically today is what is data-driven population health management, what are the types of data that we use and we can use, but as well as talking about both in terms of why different data sets are very useful, but also that there's a lot more we can be doing with the data we've already got. Then we'll look at a bit around how we can use data to shift from an illness system through to a health system, both in terms of the way that we deliver services and the population that we serve for those services, and the role that data can play in that. And then finally, we'll discuss around actually how you bring that data to life to make meaningful changes. And one of the things we'll try and focus on in that last section is actually the so what, and how do we make this useful, meaningful and actionable in our day-to-day practice, whatever our role is across the NHS. So very briefly, initially, just to recap on population health, what it is and why we're here. And so population health, as defined by the NHS England, is an approach that aimed at improving the health of the entire population, both the physical, mental health conditions and the well-being of people, whilst also exploring and attempting to reduce health inequalities within and across a defined population. At its heart, it realises that health is multi-dimensional, that it has a wide variety of drivers, that of course the NHS plays a huge role in the health of an individual and the health of a community, but also that around 85% of an individual or population's health is actually influenced by things outside of the NHS control, around social care, around public health further out into the community, and the environment that we live in, and how we can work together better to try and improve that health of the population. And at the core of population health management is using data to drive the planning and delivery of services that achieves the best impact for our populations. So the important thing with population health management is to know your population. So here we've got a chart that looks at the UK population pyramid, with the dark blue being where we are today and the light blue line outside where we're expected to be in 2040. And we all know this. We all know that there's more of us and that we're living to older ages. But that in and of itself can be useful to a degree, but just in the way that every patient who comes into the hospital or every patient that goes into the GP surgery is different, the populations are different too. And so a one-size-fits-all approach doesn't work and isn't the most effective. But what we can do is know a little bit more about our populations, both in terms of how and when they present to the hospital, but also around what they're like, what their age trajectories are, what risk factors they have, and so forth. And so on that risk factor level and that overall level, Public Health England fingertips dataset is really useful for that. So here we've got the England broken down into regions, as you can see on the top. Sorry, as you can see on the top there. And for each region, we've got the life expectancy, males and females, as well as the healthy life expectancy, initially at birth and at the bottom age 65. And the red means that they're at the lower end, that life expectancy is lower, and the green is life expectancy higher. And what the important takeaway here is that this very...
Sorry, Jonny, could I just interrupt for just a moment? We appear to have a problem with the slides. They're not moving along at all at the moment. I'm looking myself and see it's not working, and I know that one of our participants has just said that they can't see the slides either. Could
Oh,
you just reboot your screen and reshare, I wonder?
Of course. Sorry, John. Let's see.
Thank you, everybody, for your patience. That's much better. Is that okay with everybody? Could you just confirm, a couple of you? Perfect. Okay, that's working now, Johnny. Thank you.
Okay, and if I go to full screen, is that still working?
Yeah, that's all great. Thank you very much, Johnny.
Sorry for that. So the last slide here was around looking at the population, and then we moved to say how the populations differ. And here we're looking at different regions of England up on the top axis there, and on the side we've got different metrics such as life expectancy and healthy life expectancy. And the purpose here was to show that that we must know our populations, that each population is different, and that has implications both for obviously the demands of the population and also the services that we should try and provide. Again, as importantly as actually knowing about it, it's what to do with it. And one of the important things with data is that a long time, certainly in academia as well, we're very good at creating really interesting articles and really interesting outputs on data. But actually what we do with it is what is important. So again, here from Public Health England, we're looking at Eastern Cheshire, just to take an example. But we can see that if we take the England value in this column here, for example, the smoking prevalence is just under 17%. But for Cheshire, it's 12.6%. If you go to Blackpool, that's up at around near 21, 22%. And the point here is that where you target your resources and where you're going to get the biggest bang for your buck is driven by the data. And we've been doing this for a long time in areas of public health and in the NHS. But the big progress in recent years has been that we've got more data that's available and we can do more with it. One good example here is actually around the stratification according to need. So with data, what we're able to do is various different aspects. One is to say, where is the need greatest? But also to say, if we were to improve services here or there, what would the effects be? And by doing that, that allows us to inform policymakers, inform ourselves as decision makers within the NHS and how to do that. So this is quite a nice example. So we've got here, this chart shows if survival from cancer was to be equitable across all of the NHS, that there'd be 10,000 fewer deaths over a 5-year period. So simply put, if every hospital across the NHS, every patient who walked in had the same survival chances as at the best hospital, that would be 10,000 fewer deaths. And that's also actually the gap between where we are in the UK in terms of survival and the rest of Europe. And by actually identifying this data, we're able to then put more resources into cancer survival in specific types of cancer. We're seeing that prostate, breast cancer and colon cancer are those that have the worst socioeconomic outcomes, and also for specific areas. So at the population level, the data can really drive the resources and drive the story. But in terms of healthcare settings, and more practically in NHS settings today, the key is the population health management aims to target the whole population, not just which includes those within NHS settings. So whether that's in primary care, secondary care, or in the community, actually, the idea of population health management is to identify what living well means for each of us and to ensure it's as easy as possible to do that. We've been using various different types of data for an awfully long time in the NHS, with an obvious example in primary care with Q-risk. And all Q-risk score does is take 3 or 4 demographic information about the individual, what's their age, what's their sex, some index and multiple deprivation data, as well as some parameters in terms of their risk factors. And then you can predict what their chances of having a cardiovascular event in the next 10 or 15 years. That ability to predict now, we can do much more, partly because of the data that's available, but also because of the machine learning and other statistical approaches. And we're doing it in many areas of the NHS, often in some of the those that catch the headlines, with the example being of Google DeepMind and their approach to the eye scans with Moorfield. But what we'll go through now is actually some of these approaches could be used in very much resource allocation ways and to keep an eye on our own populations within hospitals. So here again, it just identifies that what the patients that turn up at the doors of hospitals or the demand at a primary care centre is not just driven by the health. So here we're seeing on the right, this is this is identifying the claimant rates, which is unemployment rates. The darker green, the higher the unemployment rates. The lighter the green, the lower unemployment rates. And you might ask, why on earth are we showing that in a discussion around health and the NHS? But what you actually find is that clustered where the highest claimant rates are also the worst health outcomes. It's with poor education, lower levels of employment, and poor health all cluster well together. So if we know all of this, we also know much more about the populations, much more about what they're likely to turn up to at hospital. And instead of just using that as an inevitability, we can do that to redefine our services. So just now, we're going to overview a little bit around illness and health. So we discussed last time on the webinar how generally one of the, within the NHS, the system measures illness through activity as opposed to necessarily measuring health. When we also take that actually health in and of itself is an asset, whether it's to an individual, it allows them to work, rest and play, to local and national economies in terms of prosperity and of course happiness. Then with some work that I did with the Chief Medical Officer, we looked at how we're actually measuring health. And too often we're just focusing on this bottom one, which is health outcomes. But actually the good health is also around your risk factors, obesity levels, smoking rates. All of those both lead to poorer health outcomes, but also often lead to one being unable to fully work, live and play. And similarly, those wider determinants of health. So what we proposed with this was a composite health index, so that the health of the nation or health of a given population isn't just the life expectancy they have or just the cancer survival rates. It's tracking a bit further upstream to say that all of these components which lead to the health of an individual and the health of a population today, but also tracking to 10, 20, 30 years down the line. Because one of the biggest difficulties we all have within population health is being able to discount and to say, some of these measures we'll do today, or investing in that IT system so we can actually track health and health factors today, will really pay off in a few years' time, and especially when there's such competing pressure on resources. And of course, health inequalities is important with all of this. And that led to various different bits of work and has now been taken up and commissioned to the Cabinet Office for the Office of National Statistics. And that's really important because if we can move to this aspect of valuing health rather than just measuring illness, then that's a much better base to be able to shift services and shift how population health is delivered. One other aspect that we should pick up on is why data is really useful is because health, just like many other aspects of our life, is actually quite predictable. So here we've got a table from the Institute for Health Metrics and Evaluation over in the US that looked at the UK population, looked at the biggest causes of disability in 2016, that you can see on the left there, and then forecasted to 2040, and then looked at the likely change in YLL, which is years of life lost. And here, common things are common, we can see. Heart disease, the commonest cause of death and disability today and 20 years ago, despite great advances in it. That will still be the biggest cause in 2040. Big increases in Alzheimer's diseases, but other than that, not a huge amount of change in the top 3 or 4 conditions. And the reason I highlight this is because whilst health of the nation is predictable, similarly local populations too. And we can use the data better to be able to forecast local populations in terms of their health now, health in the future, but also what that means for actually demand and patients turning up at A&E, patients turning up at primary care services, and similarly, even things like flu vaccines. We're able to look at the data for the past few years and tease out what are the characteristics of those who are least likely to get the flu vaccine but need it. And why does that matter? Well, if we can identify that there's a specific group, a specific population who aren't getting the flu vaccine but could need it, then we can better target our resources to really go out and find those patients, whatever their settings may be. So the key though with all of this is making the data useful. as I say, the key for the population health management has to be to take the data. What does it mean to you? How can it be useful to you? And making sure that it's there. But if we look at the data in the way that with many other industries, if we look at our banking data, we are able to get up-to-date data on our finances in the palm of our hand that's real, live time. And we're also to set up automations to tell us if we've gone into our overdraft or otherwise. The shame really should be it's the same for our health, itself a commodity and actually our most valuable one. But for population health management, the data needs to be accurate. We need to be able to be sure that it's accurately reflecting our population or activity within the health service. It needs to be timely. And too often the data that we get are either 3 or 6 months behind. And there are ways that we can get around that. Even if the data is collected less frequently, by looking at past data, we're able actually to forecast what the data may look like and then validate it every time we recollect the data. Most importantly, the data has to be interpretable. Too often many reports are produced where there's lots of interesting figures, lots of charts, but actually it has to be interpretable to everybody who might be using the data. And in this instance, that's everyone who works in the NHS. So making sure that the data actually is interpretable and understood is really important. And then finally, as we'll come on to, it has to be actionable. Data without a purpose to action is useless. One of the difficulties with the social determinants of health over the last 20 years has been that we've been told for an awfully long time that the social determinants, education, housing, and everything that goes with it, are determining a poor health outcome in the future. But without the skills, without the tools, or without the ability to do something about it, that's pretty fatalistic. And it actually can be quite difficult then within health systems to unite people around this on a common cause and to improve things. So the key is for the data to be presented in a way that's understandable, but also then provides actionable evidence. So when we look at the NHS at the moment, specifically around population health management, when we look at the integration of care, alongside that has to be the integration of data. In the same way that we can't do population health management without data, then integrating must be alongside that data to inform that. Of course, primary and secondary care is important to integrate. We need to understand how the population flows from the GP practices through into the secondary care. And by tracking patients like that, it's very easy then to identify the patterns, which patients are turning up at A&E at which time, and looking back across their last week, their last month, and were there any signs that we could have picked up on earlier, or were there any opportunities to intervene earlier? And usually there are patterns. Similarly, integrating this data with the wider population data, with colleagues in local authority across public health and social care, all allows us to give a better holistic idea of what the population looks like. We can predict for the future what that means. And as we'll come on to, that has important resource implications for NHS. But as important as that, when within hospitals and primary care settings and across ICPs, we're generating these data sets, we need also to be responsive to what the population are doing. And there's much more data now on the palm of our hand in our phones than there ever has been before. And so much of this is around, can we use this, the integration of care and the integration of data to make it easier for patients both to understand more about their health, and to do that through interacting, whether it be through their health records or being able to do digital first, but also actually to use their wearables, whether that's for their diabetes that they have a wearable, or even if it's just tracking what they're eating and their physical activity. But that's really important data that can have huge effects on what their risks are, but also very useful to clinicians, to managers, and to patients. But alongside the data in terms of to plan the resources, it's also extremely important and useful to be able to evaluate models of care, to evaluate integration, and to then iterate. And again, this comes back to the importance of the data that we're generating being timely. If we're able to do relatively real-time data when a new model of care is being introduced, for example, for the diabetes pathway in a given area, then pretty quickly we're able to compare with past months, with the month this time last year, to see, is this working? If not, can we iterate it? And where in the pathway are the biggest opportunities to make the patient pathway smoother, both for them and also for the health systems? And the final part is that with the data, it's actually extremely helpful then to make the case both, of course, within the NHS, but within our colleagues across in local authority, that actually good health and a health system that promotes health is an asset, of course, to the NHS, but also to local authority and the wider economy. One of the areas that we've been increasingly interested in is a command center type approach. So with data analytics, both in healthcare, but much broader specifically, we should be able to monitor what's going on within a hospital, what the patterns of demand are, people coming through the door, what the bed availability is, and what the biggest triggers are for either people coming into the hospital, but similarly actually getting patients safely home or to another location. With advances in machine learning, we're able to forecast actually what the population is doing and what we'd expect then in terms of demand in the coming week or different times of the day. And that has big implications actually for matching the staffing of wards, staffing of A&E, and staffing more broadly to match that to when the demand is most likely to be high. Just like with weather, just like with traffic patterns, health is predictable. There are always black swan events that we can't predict, but for day-to-day and generally, there's a lot of forecasting and predictability that we could do that would help us to plan resources further. And more than that, some of the really exciting work with these command centres is that you can actually map what's happening in our hospital with the primary care, wider population health, but also with non-health data. So how about integrating, when we're trying to do a flu vaccine program, integrating that with Twitter and Google searches, which specifically either are looking at flu or Google searches for what's the flu vaccine or what are the flu symptoms. We have the data now to be able to map that to specific locations, whether we know that's in our hospital catchment area or primary care catchment area, and then target specific resources to try and improve that uptake. And we can get much smarter around using non-health data to improve our health outcomes. So finally, that brings us on from a command center to looking at data dashboards. So dashboards are really useful in various different ways. And the idea is that it's bringing all of that data into a usable user interface that's both interpretable and also tells us what are our options. So this is one, the global burden of disease, which has come out a little small, sorry, but what this does is we can see here in the top right corner, this is what we saw earlier in terms of the top causes of death and disability in the UK now and in 2040. And you can get on a screen here saying how the population is likely to change, what are the levers that are most likely to influence and improve our health, and that can inform decisions. So I'm just going to finish by giving an example from the academic world in public health with a group in Liverpool who've worked with their local council around the NHS health checks. As I say, data forecasting and simulation modelling has been used in all sectors, and health is gradually catching up. But one example, up in the University of Liverpool, working with their local council and NHS partners, developed a specific policy model. So importantly, that has the epidemiological engine, which has all the data about the local population. That's what's the age profile, what's their risk in terms of heart disease, and how that's spread, and how often people are interacting with the health checks at the moment, and whether that NHS health check is improving their health and by how much. We can also put on top of that the cost model. How much does it cost to do the NHS health check, and how much are the costs of health events that happen or actually are saved because of that? So what this then led to was some work between the university and the local authority to look at the NHS health checks and what the different options were. We were able to do scenario planning to look into the future and say, if we were to do this or to do that, what might that effect be on health and also on the costs of the council and of the NHS. So here you can see we've got a graph in the top left corner here. On this axis here, we're looking at the years, so out to 2040. And this is the probability of a given scenario being cost effective. And the cost effective takes the NICE approach. That's the NICE guidelines approach of around £20,000 per QALY. And so the green here is the current approach to NHS health checks, which I'm sure as many of you all know, looks to do 20% of the population each year and all 5 years. But what we know about health, that it's predictable, and we know that risk isn't equally in each 20% of the population. So the team explored 4 other options, which include a more targeted option, that is identifying through the data which populations are most at risk and targeting those specifically in succession years, rather than just targeting 20% of the population randomly. The risk of a population isn't random, and so our approach to reducing that risk shouldn't be. This optimal policy here was if we could get optimal uptake. So if we can improve uptake of the NHS health checks through targeting those who are most at risk, and also and doing such in a resource efficient manner, that we're going out to where the risk is highest. And options D and E combined that with work that the local authority were doing. So what if we were to improve the NHS health checks by making it targeted at those most at risk, and alongside that we were to do some structural approaches and actually reduce the salt in the food that you could buy in the City of Liverpool, introduce mandatory reduction in salts, and the sugar sweetened beverage tax, which we know came in 2-3 years ago. And what this showed was that it would be cost effective much quicker, it would save many more lives, and actually be much more cost saving to the NHS. And this work here was really useful for the local authority and the NHS to be able to look at what the possible options are, what different scenarios might cost, and what the benefits would be. And this ordinarily would replace a randomized controlled trial where we could do all of these in different places and find out in about 10 or 15 years. And the beauty of the scenario analysis is that we can do all of this within a computer simulation, understanding that it's imperfect, and then to guide us into making informed decisions. So I hope that's a bit of an overview of the types of things that we can do with data, say right from the local authority into sort of command centres and understanding what the patterns of flow are within a hospital and how we can actually forecast that to try and better match staffing and everything that goes with that. I'm very glad to take any questions if there are any.
Thank you, Jonny. I thought that was absolutely fascinating. Actually, it got better as you went along. I really enjoyed the last few slides there. We've got a couple of questions. If you've not yet typed in a question, you've still got time. Please do so straight away. I'll address the first ones. The first question we had was, who is best placed to create the intelligence for population health managers, population health management? Providers, CCGs, CSUs? What's your opinion in that regard?
Yeah, that's a great question. It's a great question, and the answer is a bit of a fob off, which is that everybody. Part of the difficulty, I think, is that everyone within a health system is incentivized. The data that they need or the data they require is incentivized according to their incentives. And so for hospitals, it's to collect the payments tariffs, CCGs, where that's going. If it had to be one group, CCGs are perhaps the best place for that because they have that overview. But this is where I think the integration agenda really comes in, that if we can use the ICPs to have population health management at its heart, then it's that coordination of data. One thing I think we want to avoid is making population health management only the business of public health or only the business of primary care. Because really, as we can see, we could do that in both secondary care, primary care, local council, and across third sector. And so one way of doing that is ensuring that it's a coordinated response to how we collect the data and then inform the data.
Thank you, Jonny. Question number 2, we've got 4 questions that we've now got in. Question number 2, how much BI resource is needed to have a good stab at population health management?
It's a really good question. So it depends what setting that you're talking about. So one of my firm beliefs is that actually we can all do population health management and that data is required to do population health management. So every healthcare setting that you work in has data in-house. So if you're in a hospital or if you're in a GP setting, if we take a GP setting, just one practice, irrespective of the PCN working together, then looking at that data set, we'll be able to actually interrogate that to see where are the patterns of demand, where is demand highest, and what does that look like? And just by looking at that, actually, we'll be able to see which patients are driving most of the demand and what are the possible interventions that could reduce that. But the more we look at it, the more we realize how people cluster, that there's a specific group who actually have 10 appointments in a month. And one of the driving conditions with that, for example, is diabetes. And this is a very obvious example. But so what you might do is then look at, what if we put a specific clinic on this day with a clinician who is specialist in diabetes, does that work or doesn't it? But by interrogating that data, you're able to look at, you bring out the data, you then speak with the specialists, the clinicians on the ground, the staff in the GP surgery, and then can look at what the possible options might be and can monitor that. So in short, a lot of the infrastructure is already there. What often isn't there is the combination of some of the skills. These are often from actuarial science and others, but also the incentives to collaborate really across that sector.
Thank you, Jonny. Good answer. Question number 3, how do we make the, oh, this is a good question. How do we make the IG elements of population health easier?
Sorry, John, I didn't quite catch that.
How do we make the IG elements of population health easier?
The IG, oh, sorry, information governance, sorry. Yes.
That's all right, don't worry, everybody loves an acronym, Jonny.
That's a really good question. And I'm not sure I'm best placed to answer it. I think what one of the keys would be for the ICP process creates a good opportunity for population health. And I think it will be a really missed opportunity if we don't do that. And so embedding these types of processes and the governance issues within that from the outset is our best chance, I think, to actually set the framework up. As I say, it's very easy, because it's difficult, it's very easy to pass the data aspects to one side, especially because most of the gains that we could get from this will be further down the line in the next 3 and 6 months. So, as I say, I'm not best placed to answer that, but I think that really embedding it within the ICP approach would be a really effective way.
Thank you. Next question from Lex. Thank you, Lex. How can we use a command center in a GP practice?
It's a great question. So I think, and so this is one where undoubtedly there's a question as well, of course, of resource. Clearly, to create a command center does have some resource implications, but that there similarly would be cost savings through various different approaches in terms of, as we've discussed, reallocating, whether that's the patterns of demand or also how you're matching the staff to that. So I think that's where PCNs potentially have that potential, because we're, of course, I don't know what size GP practice you work in, but that once we're at that little bit bigger population size of 20 and 30,000, then the economies of scale there obviously comes to start to play in. To create the command center, actually, when we're looking at integrating that size of patients, it's not really what the difference is then, is actually to have a technology tool that's a platform. So it's going from, a lot of that data is there, it's really just creating the technology platform so that we have it in an easily readable and relatively timely way. And so I think using PCNs, which obviously have a function and a purpose to deliver population health management, to create that command center approach through this technology platform is the way to do that. And that's something that PCN should really work into.
All right, thank you, Jonny. Final question, and Lex, I hope that was useful to you. I would say to all of you who've been listening this evening, Jonny has put his contact details up there, and I know of old he's very reliable in terms of returning questions that you may have, so do please contact him directly if you'd like to. Final question is from James, who asks, as well as health and social care, what opportunities are there to work with other sectors who hold data on the population? For example, police or fire services, courts, probation services, and such like?
I think that's a fantastic question, and really where population health management really needs to sit. So the question was in terms of opportunities, was it? So yeah. I think so I think that's where public health moving into, so all of those that you named in the question are extremely relevant, and anything we can do around the social drivers of health clearly will have massively beneficial impact. Public health sitting within local government, local authority, is a huge opportunity for that. And that one of the big rationales for that was that then they are sitting alongside colleagues in housing, education, and many of the other areas that you mentioned. So I think our public health colleagues in local authorities are crucial to this, in that if the collaboration between them from local authority and the NHS will really open that door to fuller collaboration, the different data sets, and of course, all of the third sector work as well that goes on, that the local authorities and councils generally are very well placed to do. So I think public health within local authority is a potentially huge gateway actually to really addressing and embedding a more holistic approach through those other services within local authorities in collaboration with the NHS.
Terrific. Thank you, Jonny. Well, look, I'm sure everybody would join me in thanking you once again, Jonny, for your sterling presentation. We are going to have another one in this series later on in the year. For now, our next webinar through the Institute of Healthcare Management is on the 3rd of March, where we've got Mark Robb, who's a partner at Positive Reframe, who's going to talk to us about high performance leadership for the 2020s. That is a not to be missed one. I know Mark of old, and he's a fascinating presenter with some really good tips and ideas for how you can do that. All that remains for me to say is thank you very much on behalf of the Institute of Healthcare Management for joining in. Thank you once again to Jonny Pearson-Stuttard for his fantastic work and for dedicating so much time to us. And we look forward to seeing you all on another of these webinars the next time we have the pleasure of meeting. Thank you very much for coming along. Bye-bye.